All right. Good afternoon. This is the Department of Internal Medicine Grand Rounds. Today is Thursday, November 9th. So today's session is sponsored by the Division of Endocrine, Diabetes, and Metabolism. Happy to have Dr. Wickham here. So Dr. Trey Wickham is an Associate Professor of Internal Medicine here at VCU. He's trained in internal medicine and pediatrics. He obtained his PA in environmental sciences from the University of Virginia and then went on to get his medical training here at VCU for both his combined residency training in internal medicine and pediatrics, as well as his fellowship training in endocrinology. He's board certified in obesity medicine, and his clinical practice focuses on the care of patients with diabetes, obesity ranging from youth and adults. And he's reportedly, or he is, I don't know why, repeatedly recognized as one of the top docs in Richmond.
Or reportedly.
That's awkward. He is one of the top docs in Richmond, recognized repeatedly. Sorry about that. Dr. Wickham is a NIH-funded clinical investigator and has an active research portfolio, including clinical trials looking at treatment options for obesity in adolescents and emerging adults. We are happy to have Dr. Wickham here. Let's give him a grand round of applause and have him lecture.
Sorry about that. Oh, you were totally fine. It is certainly a pleasure to be here. And I have plenty to kind of share on. And, I had to update this presentation just within the past 24 hours, as you'll see here in a second. But as far as kind of getting started, disclosures, in addition, I am a member of the executive board of the American Board of Obesity Medicine. And the presentation includes the discussion of the off-label use of phentermine, tirzepatide, as well as topiramate. Oh, wait a second. Tirzepatide is no longer off-label for the indication that I'm going to talk about within the past 24 hours. But sort of all kidding aside, the care of patients with obesity in a compassionate and evidence-based manner is something that I care about a whole lot. And even if you're not someone that's going to be prescribing weight loss medications, I'm going to propose to you that the care of patients with obesity is an important part of each of our practices, regardless of what your discipline is, and as far as your background. And that's because we are going to care for a lot of patients with obesity. And, it's estimated that over 40% of the US population would have a BMI in the category that would be consistent with this. And although we can have debates about kind of how reflective a BMI is about a truly identifying risk, what I do think that we can agree upon is that patients that have excess adiposity or obesity are at a high lifetime risk of a multitude of different health conditions. So a shout out to my GI colleagues here. I'm using the correct term of metabolic dysfunction associated fatty liver disease, or MAFLD now, as we're calling it. The other thing I want to just point out briefly before we move from this slide is kind of the last one, depression. And I would expand that out to talk about impaired quality of life, because I really do think that that is something that is significantly under-recognized in our patients with obesity, just how this disease impacts so many facets. And the study I love to talk about, not because it's great, but just because I think it is so informative, is one that's about 15 years old now, where it was looking at adolescents with severe obesity that were seeking treatment for their weight. And they were administered standardized quality of life scores. And the results of those were actually compared to youth that had other chronic health conditions. And the youth with severe obesity reported quality of life scores that were lower than the kids that had active malignancy and were undergoing treatment with chemotherapy, right? So, and I don't think that the impact of this disease on our adult patients is any less meaningful. But an important thing to kind of consider. Now, when we start to talk about what is caused obesity, it is true that weight gain is the result of a positive energy balance, where energy intake exceeds energy expenditure. However, I'm going to suggest that this concept and its application to the treatment of obesity has been injuriously oversimplified to suggest that obesity should be easy to fix. People just need to make better eating choices, eat less, and exercise more. And I wonder how often that is the advice, and actually where it stops in partnering with our patients with obesity. And with this paradigm, obesity has been inappropriately reduced in many cases to a moral failure. People should just work harder, work better, or just a lack of willpower, right? And yet we know that like many health conditions, there are strong biologic underpinnings that influence this process of energy intake and energy expenditure, one of which is genetics. But I know we're going to talk about pharmacotherapy, but I really want to take just a quick detour here to emphasize the concept and our understanding of obesity is a complex chronic disease. Because I think if we don't stop here and recognize that and reflect on that, then it makes understanding why pharmacotherapy could be an important part of the treatment less meaningful, right? So again, we know that there's strong genetic contributions of body weights, and it really depends on the study, but anywhere over 40 to 90%. For a few individuals, this is because of very specific genes, and we know that there are monogenic forms and syndromic forms of obesity. But for the vast majority of people with elevated body weights, the genetic contributions are the results of cumulative effects of multiple genes, each accounting for only small variances in body mass index. We also know that there are intricate neurohumoral and enteroendocrine pathways that directly influence appetite and energy intake, as well as satiety and energy expenditure. And you see just a few of the factors that we know are secreted by a variety of different organs, kind of coincide in the CNS to regulate these behaviors. And as we start to talk about our medicines and the ones that we're developing these days, like a lot of these pathways are going to be kind of at the heart of that. But I think it's also important to recognize that the health problem of obesity is not the sole result of factors at the individual level. And many of you, if you've heard me speak before, have seen this slide, which is several decades old now, but was done with work out of the UK. And I appreciate that you can't see the words on it. That's part of the point. But what the group did is they actually tried to identify all of the different primary factors that contributed to the obesity epidemic. And each small box there you see represents a unique one of those. And then the lines are how these factors kind of interact with one another to ultimately to contribute to this health condition. And they, again, you can see it was not only at the individual level, but things like the physical activity environment, food consumption and production, as well as social psychology. I could spend an entire hour talking about the different components of this slide, but again, giving you this sense that there are many things that we know that contribute to the epidemic of obesity. We've referenced kind of the genetic and epigenetic components. We know that many things structured in our lives, including sedentary time, how we spend work, impaired sleep, contribute. And what I think is most important here on this slide is how the larger environmental and social constructs contribute to this. I've already mentioned food policy with things about our built environment, socioeconomic factors, and even exposure to endocrine disrupting chemicals. And these all coming together to kind of contribute to this complex chronic disease. And I think I would be remiss if I didn't really highlight the evidence that we know that a strong contributor to obesity is actually many of these environmental factors that arise from systemic racism, as well as health inequities. So this is not a simple problem to address, right? Like we need to be looking at all of these things in the comprehensive treatment of obesity. So really what I want to leave as we jump into kind of thinking about medicines is to leave you with this, is that at the core pathogenesis of obesity is the sustained positive energy balance. But we also know that there's a resetting of the body weight set point at an increased level. I didn't share this, but we know that there's pathways that we taught that I just briefly highlight up there. When an individual loses weight, there are adaptations or changes that happen from that actually promotes weight regain. And it's those two together. And at one point during human development or human history, not so long ago, having a genotype that actually was metabolically conservative, right, that would be a real survival benefit. That, being able to kind of weather a drought or kind of storm where there was excess famine was of benefit. But now all of a sudden, those kind of genetic contributions are put in the setting of an environment that really kind of where there's a variety of different kind of high energy kind of foods and things like that. So again, really this concept that obesity is a complex chronic disease that results from the interplay of a myriad of genetic, environmental, metabolic, and behavioral factors. And this slide keeps wanting to go this way. So now let's talk about the session objectives. And so it's really in that context that I want us to understand the role of pharmacotherapy in the comprehensive treatment of obesity. I want to spend some time comparing and contrasting different mechanisms of action, clinical responses, and the risk-benefit profiles of currently available anti-obesity medicines. And hopefully to kind of come back together and to talk about the guiding providers in implementing and monitoring pharmacotherapy in the context of an individualized, patient-centered obesity treatment plan. When we think about the primary treatment modalities available, really it's lifestyle modification and behavioral support, pharmacotherapy, and metabolic and bariatric surgery. And again, we could talk about any one of these kind of in great detail. And so just really up, I would say until recently, the main cornerstone, the only kind of therapy available to the vast majority of patients with obesity has been lifestyle modification, right? And I don't want you to leave this lecture today thinking that lifestyle modification isn't important and that it doesn't work. It is an absolutely essential part of the comprehensive treatment of obesity. But for such a complex disease, and as we'll talk about, it actually may require more than just lifestyle modification. And you see the results of a meta-analysis that's some years old, but we really don't have anything new that suggests that lifestyle modification does result in a significant reduction in body weight. And at first you might be going, gosh, that is not very much at 3 kilos when we look at this. Look at this meta-analysis. But another thing that I think is extremely important is that we put the context of what are the benefits of different degrees of weight loss as far as health outcomes. And so you see a summary of that information in this slide here. We know that weight changes as little as 3 to 5% can have significant improvements in metabolic health. You can see improvements in insulin resistance, begin to see improvements in diabetes. For patients with dyslipidemia, lower weight losses are associated first with decreases in triglycerides. When you start to get closer to 10%, you can see increases in HDL. Hypertension, you'll also see kind of reductions in systolic blood pressure first, followed by those in diastolic. So several other weight-related health conditions do require larger amounts of weight loss before you start to see improvement. That's kind of the next group there with MAFLD, gastroesophageal reflux disease, obstructive sleep apnea. We also can see improvements in reproductive health with weight loss of even small amounts, both in PCOS and male hypogonadism. And I put this up because one of the things that we'll talk about, or you see frequently in trials looking at treatments of obesity, is this clinical threshold of greater than 5% weight loss being clinically significant. And it's really data like this that's kind of supported that. I think it's important to know that greater reductions in weight may be associated with further improvement as well. All right, well, let's go kind of to the opposite end of kind of the treatment spectrum potentially, which is kind of talking about metabolic and bariatric surgery, which we have more and more robust and long-term data that metabolic and bariatric surgery is a safe, efficacious, and durable treatment for obesity. Many of us have the perception that the majority of patients after bariatric surgery will regain their weight, or they all have complications. That's not what the data shows, us. And what I wanted to show here again is that bariatric surgery does have sustained ongoing weight losses of 20 to 30%, but depending on what type of procedure that you're looking at. We also know that long-term metabolic and bariatric surgery is associated with reductions in mortality that continue to separate for decades out after. And important to our patients with diabetes, we know that bariatric surgery is associated with both a reduction in the progression and development of microvascular complications, as well as macrovascular complications, so cardiovascular disease. And we'll talk more about kind of that particular outcome just in patients with obesity in general later in our talk this morning. All right. Well, what are we here to talk about? Well, let's talk about the role of pharmacotherapy. And it has been for some time recognized that there are medicines that may be the appropriate part of the long-term treatment of obesity as adjuncts to dietary therapy and physical activity for patients with a BMI above greater than or equal to 30 with no other risk factors or weight-related conditions, or a BMI that's greater than 27 with other risk factors or conditions. And I highlight this for a couple of reasons. So these kind of criteria or guidelines are all of the ones that are going to be the entry or inclusion criteria for the trials that we're going to talk about. These are also the ones that match up exactly with what the FDA approved indications are for the use of these medicines in the long-term treatment of obesity. And all of the trials are going to assume that at baseline, it's part of a comprehensive treatment that includes lifestyle modification. Now, before we talk about specifically about medicines to induce a weight reduction, I think it's really important to talk about the medicines that we may prescribe as providers that do the exact opposite of maybe what we want for our patients and maybe what they want, which is those that induce weight gain. And I want to give a shout out to my friend and colleague, Dr. Stephanie Meir at the VA. This chart is one that she developed as part of the VA and Department of Defense national guidelines for the treatment of obesity, of which she was a champion and primary author. We're not going to go over them in detail, but really just to recognize again, for lots of medicines that we use frequently, they can actually have a negative impact on weight. And when possible, we should be thoughtful about selecting medications that could also treat what other health condition a patient with obesity or overweight may have, but reduce kind of the risk of weight gain. So some of them that I think we think about less frequently is maybe some of our beta blockers. So certainly the progestin, so Depo-Provera is one that's well known to induce significant weight gain. The last one there is one that people often overlook, which is antihistamines, including those agents that are over the counter. So Benadryl use is associated with weight gain. So being thoughtful about these and selecting agents that are more either weight neutral or weight reducing. I also want to recognize that as we're talking about pharmacotherapy for obesity, there's a lot of history here, right? And not necessarily a lot of good history. And there's many stories that we can tell about medications that were FDA approved and then ultimately shown to have significant adverse effects that resulted in their removal from the market. Now, one of the things that I'll say is that as we've kind of learned in a field from this, that there are much more rigorous kind of undertakings about looking at safety than ever before. But I think we have to recognize this history. So this is a list of the current, and as of again yesterday, there's 8 FDA approved medications for the treatment of obesity in adults. You can actually see by the asterisks there that for 5 of them, we actually have approval in the pediatric population down to age 12 or 16, depending on which agent that you're looking about. We're going to focus today on the last 5 on this list, which are what I would say are kind of the newer agents and the ones that really have the largest clinical impact on the care of patients with obesity. So the first one we're going to talk about is phentermine topiramate combination. And so for these first couple medicines, and there are more coming, part of the thought is if we put different agents together into a single pill, one, maybe we can use lower amounts and kind of minimize any adverse effects while maximizing kind of impact on weight. And so phentermine works. It's a sympathomimetic amine, which stimulates the hypothalamic release of norepinephrine and suppresses appetite. And has been approved for the short term, defined as less than 3 months, treatment of obesity since 1959. I'm excited to share that a colleague that I know at Wake Forest, they're actually doing an NIH-funded trial looking at phentermine monotherapy as a long-term treatment, partly because, as we'll talk about, there are access issues with many of these meds, and we need to be able to utilize everything kind of within our toolkit to help support patients. And phentermine monotherapy is relatively inexpensive. But this agent combines it with topiramate, which has previously been approved for the treatment of epilepsy and migraine prevention. And its development as monotherapy for obesity was hindered by neuropsychiatric adverse events, including memory disorders and depressions. Like people almost talk about it as kind of like a brain fog that they can get potentially with topiramate. Well, here are the results that you see. And all of the studies are going to assume that this is in addition to intensive lifestyle modification. And in this particular study of over over 2,000 adults with obesity that were treated with either phentermine topiramate combination or placebo, there were significantly greater reductions in kind of weight, up to almost 10%, kind of with the highest dose of the phentermine topiramate combination. And I'm going to, for each of the trials I go over, I'm also going to show you this information, which really starts to look at kind of those different thresholds, right? So over 60% of patients on phentermine topiramate lost greater than 5% weight loss, and over 40% or approaching 40%, depending on the dose, lost over 10% weight loss, right? So it's a significantly meaningful clinical reduction in weight. So phentermine topiramate has been, as a combination, has been approved for the chronic treatment of obesity, again, with those guidelines that we talked about as far as the criteria since July 2012. I'm not going to go over all the dosing details with you in detail, but I will say one of the things that's nice about the extended release combination is unlike if you were using either of these agents together, but as a separate pill, the extended release formulation does allow for once daily dosing. The recommendations is that you start at the lowest dose, titrate up 2 weeks later to kind of the mid dose. You're going to reassess, and this is going to be a very consistent theme throughout the use of pharmacotherapy, is once you have a patient on a standard dose, you reassess their clinical response. In some cases, you go up if you haven't reached that clinical threshold. If they're at the max dose and there's not been a meaningful clinical response, then you would actually discontinue or wean the medicine, depending on which one it is, and consider something else. So there's kind of those two steps with the phentermine topiramate, and I did put at least with the prescribing information what the brand name is. So this goes by the brand name of Qsimian. So what are the side effects that we need to continue or consider with this? And we're going to come back to pregnancy in just a second, but the more common side effects it doesn't cause pregnancy, but we worry about the teratogenicity associated with it. So this medicine, actually, like almost all of them with the weight loss medicines, are associated with tachycardia. And we already talked about the potential for topiramate in some cognitive disorders. It is associated with the development, it could be with a metabolic acidosis, and predispose to renal calculi formation. So it's contraindicated in patients with active nephrolithiasis. So let's go back to this pregnancy risk. And part of the reason that I'm bringing that up is that when this medication was released, and the continued recommended standard of care is that prescribers should be enrolled in a risk evaluation and mitigation strategy, or REMS program. Part of that recommendations is that individuals that could become pregnant on this medicine should have a urine pregnancy test before starting the medication, and then monthly for the duration of the therapy. So we are talking about lifelong therapy here, right? So I don't want to minimize the potential kind of teratogenic effects of this medicine, but it is not higher than many of the other medications that we use all the time and don't require patients to get monthly birth control pills on. I would propose that part of what's happened is that this is discrimination against patients with obesity. It makes it harder to get this medicine, potentially, to find a prescriber that's willing to do it. As I've started to talk to many of colleagues across the country, the vast majority of us are talking about what are the risks with patients, of course, with that. But really leaning back on what would you do for any other medication that was teratogenic? Would you get a monthly pregnancy test for that? If you would, absolutely do it with this medicine. If that wouldn't be part of your standard practice, I would encourage you maybe to follow that. I do recognize that that's different than what it's here, but we don't recommend that when we use topiramate for migraine prophylaxis or for seizure treatment. It's only in this indication where that's been proposed. All right, the next medicine that we're going to talk about is the combination naltrexone-bupropion. And bupropion was previously approved for the treatment of depression and smoking cessation. We think part of its mechanism of action in the treatment of obesity is stimulating hypothalamic pro-opioid melanocortin, or POMC neurons, to suppress appetite. That's combined here with naltrexone, which is an opiate receptor antagonist that has been used in the management of alcohol and opiate dependence, but blocks opiate-mediated POMC autoinhibition, so basically magnifying the effects of the bupropion. And it's proposed to synergistically reduce food intake and modulate mesolimbic Board pathways. So what do we know about clinical responses with this? So again, in a randomized double-blind placebo-controlled trial, here it was the core one, showed significant and sustained reductions, although in body weight, although not as quite as robust as phentermine topiramate combination that was sustained out for up to a year in patients. So what are this? And here you can see that again, over 40% of patients lost greater than 5% body weight with this medication. Roughly 20 or to 25% lost 10% or more. And there was a subset of patients, roughly about 10%, that lost 15% or more weight loss. Now, one other thing I'm going to encourage you to think or watch is as we go to these more potent and newer agents, you're going to see the thresholds that they report continue to expand, right? So we're going to see 20% weight loss, 25% weight loss, and maybe even more than that. You'll just have to wait and see. So what do we know about prescribing this medicine? It's been FDA approved for the chronic treatment of obesity since 2014. It is ultimately at its highest dose, the 2 tablets twice a day. And then you want to evaluate weight loss after 12 weeks. Again, similar story. If it's less than 5% weight loss, you want to discontinue. Therapy. One thing I forgot to mention when we talked about phentermine topiramate combination is because of the risk of rebound seizures, you do not want to stop that medicine, particularly at the highest dose suddenly. And so what's recommended is you have the patient take a dose every other day for a period of at least at least a week if they're discontinuing that medication. All of the other ones can be just stopped if you haven't had a clinical response. So what are we worried about with this combination of medicine, which goes by the brand name of Contrave? This one, unlike the other ones, is associated with an increase in blood pressure. So you do have to be cautious in patients that have uncontrolled hypertension and continue to monitor blood pressure. It can lower the seizure threshold, and then you can see some of the other kind of adverse side effects there. Where we're going to spend the last part is actually talking about our newest kind of class of medicines. And recently they've been kind of lumped together in a category called nutrient stimulated hormone therapy, or NSHs. So what you see here are a list of just a few of these nutrient stimulated hormones that are part of kind of normal physiology. Most of them are kind of derived somewhere along the GI tract, get secreted based on intake, and then, as we'll talk about, modulate energy intake and energy expenditure. And where we're going to start on this list is glucagon-like peptide 1, or GLP-1. Right, so let's think about kind of what the effects. So these medications, many of which were first designed as treatments for diabetes. So we know that GLP-1 receptor activation has significant impact on pancreatic function. In particular, it stimulates insulin in a glucose-dependent manner. That's one of the things that makes it very attractive as a medication for the treatment of diabetes, because it only stimulates insulin secretion of these class of medicines when blood sugar is elevated. So hypoglycemia is not a common side effect. It delays gastric emptying, which also can help with postprandial glucose excursions. It suppresses glucagon. But where we're going to really focus most on is kind of the impact on the brain. And so we know that there are GLP-1 receptors throughout the CNS, and we think that activation of this has a direct effect on suppressing appetite and modulating energy expenditure. Side note, we also know that there are GLP-1 receptors on the heart and the vasculature. We're going to come back to that in just a second. Well, there have been several medications now that are analogs of GLP-1 that have been approved for the chronic treatment of adults with obesity. Just to give you a quick other tidbit about GLP-1 physiology is that in normal physiology, GLP-1 that's secreted by the L cells in the distal small intestine is rapidly degraded. It has a half-life of about 2 to 5 minutes, and that's degraded by an enzyme called dipeptidyl peptidase 4, or DPP4. But all of the analogs that I'm going to show you and that we talk about and we use for these pharmacotherapies have been modified at the area where the DPP4 enzyme would break it down to provide a substantially longer half-life. The other thing I think it's important to recognize is the doses at which we're administering these medications are these hormones that have been modified are not really at physiologic levels, they're at pharmacologic levels. So we are giving doses of GLP-1 that are higher than what would typically be circulating with that. And the first one that was approved was liraglutide. It is dosed daily at a dose of 3 milligrams a day. And here you see the scale trial that involved almost 4,000 patients with obesity that were treated with daily liraglutide in addition to lifestyle modification. Again, associated with significant and clinically meaningful reductions in body weight. All right. And here for this particular trial, 62 or 63% of patients lost over 5% of their body weight, and over 30% losing greater than 10%. Now, the data I'm showing you here is actually from, so this is one of the agents that's approved for use in the pediatric population. And this was the data that led to FDA approval. But what I want to highlight is something that really we haven't seen yet on any other slides, but is true for all of the medications. So that's when you look at the line here, which is where the medication was stopped, what actually happens. And so with all of these medications, there is weight regain that occurs when the medication is discontinued, right? So that's an important concept to understand and also for us to discuss. These are really medications that are intended for the long-term treatment of obesity. That often is that surprises people. I'm like, well, why would we use these medicines if you stop them and the weight comes back? How is that any different than any other complex chronic disease that we manage, right? Like we don't naturally expect like, oh, when somebody's blood pressure is at goal, that we just remove them and that their blood pressure is gonna stay the same. But again, I would, if that is something that you wonder, like I would encourage you to kind of think about how are you viewing obesity as a complex chronic disease? So as far as prescribing information for liraglutide, its weight loss version, it goes by the brand name Saxenda, again, approved in 2014. So you basically increase, so it's once a day injection, you increase the dose weekly up to the target dose of 3 milligrams. As all of these things, after reaching kind of maximally tolerated therapy for a period of 3 to 4 months, you reassess. If there's not been clinically significant weight loss, you'd want to discontinue therapy. So the other GLP-1 receptor agonist that's been approved for the treatment of obesity is semaglutide. And this is the STEP 1 trial. Again, very similar design to all of the ones that we've talked about, a randomized placebo control trial, which shown now we're reaching with this medication, which is administered as a once weekly injection at 2.4 milligrams, 15% weight loss on average out at 6 weeks. And you can see here, 86% of patients on this medicine lost greater than 5% weight loss. Over 50% lost greater than 15% weight loss, right? So this is weight losses that are going to consistently often improve all of the comorbidities that we saw listed there earlier in the slides. And so since it is weekly dosing, the recommendation you start on a low dose, and we'll talk about why with these in just a second. As far as that, you escalate doses once a month as tolerated up to the maximal dose of 2.4%. Again, reassessing clinical response and discontinuing if the medication did not have a significant response. So let's collectively talk about kind of the adverse effects of the GLP-1 analogs. And I'm going to spend a little more time on this because I think there's some things that you see on the television and controversies that come up that are worth kind of discussing in a little bit more detail. So certainly we know that nausea, vomiting, diarrhea, and even constipation. So GI side effects are the most common with this. And if you look at trials, it could be anywhere between 30 to mid 40% of patients reporting GI side effects. Now, they're often not significant enough that they stop therapy. Sometimes they are with that, but it's the most common. That's why with these agents, we start at a low dose and slowly work our way up. It's also important that as much as possible, therapy is not interrupted because if a patient, again, has missed several doses and then back on kind of the full dose, it can increase the risk of nausea and vomiting. Now, I want to just express something that I've seen clinically. So I have had patients either coming to me where they've been on these agents and because of the nausea and vomiting have been also treated with daily antiemetics or requesting that as part of the treatment. I would urge you to be very cautious about that approach. My clinical practice has been if with a dose titration, the patient has 1 or 2 days of significant nausea, I may prescribe a handful of those medicines, but I think that you should consider a different agent if the patient is chronically experiencing nausea and even MS significant enough that they're requiring medicines to specifically treat that. Something we'll come back to, but as these medicines is that I think we need to worry about adequate intake for some of our patients with this. They can be so suppressive with appetite. It is absolutely important. None of these medications are just give them to the patient, and if they're losing weight, everything's great, move on. You need to be reassessing dietary intake. And I think when our patients come back, you need to assess, hey, how are things going? You will meet patients on these medicines where they are eating very little. And that is not how again, what we want kind of long-term with these particular patients. And it may require kind of a dose reduction with that. Another common side effect that I see, it's certainly not as common in the GI, is hypersensitivity reactions. So with any injectable therapy, it's important to coach our patients on the correct places to inject it, as well as to look at the injection sites whenever they're coming to clinic. And what has been described with the GLP-1 analogs that are administered subcutaneous are these local hypersensitivity reactions, and you see some examples here. Most commonly, they're not associated with more systemic symptoms, although rarely they could be with that. But patients will develop kind of these like erythematous wheals that are several inches or larger. And so I counsel them that they need to contact us if they develop this. I've seen some patients develop actually significant scarring from this that just doesn't resolve. One of the nice things is if the patient hasn't had more systemic reaction and it's just been a local injection reaction, you can actually try other agents within this class and they may not have a reaction with it, but definitely want to look at that. All right, well, getting to some of the more controversial things on the list is pancreatitis and gallbladder disease. So I already highlighted to you or for you that these particular medicines have receptors all throughout the pancreas. And so there have been some concerns because of kind of hyperstimulation of the pancreas. Do we increase the risk of pancreatitis? And so here are the results of the meta-analysis. And I'm going to tell you all of the meta-analyses I'm about to show you about kind of potential for adverse outcomes were not specifically just in patients that had obesity, but they were largely derived from our previous trials involving patients with type 2 diabetes as well. And part of that's why that's important is that when we're talking about pancreatitis, patients with diabetes, both type 1 and type 2, are at higher risk of pancreatitis compared to patients that don't. But when we look at this meta-analysis involving over 25 trials and over 30,000 kind of participants, there was not a significant increase in the number of cases of pancreatitis across kind of all of these together. There were 60 cases of pancreatitis reported in patients on therapy and 55 in treatment. So, the FDA recommendations are that you would stop these medications in patients that have pancreatitis and not use them if a patient had previous kind of pancreatitis. Now, I do know that there are some people in the field that if there was a obviously identifiable cause of the pancreatitis, right? Like, so somebody had gallstone pancreatitis and their gallbladder has been removed, or they had ERCP and developed pancreatitis afterwards, that you may, after a very detailed kind of risk-benefit kind of discussion, consider that. I might say that that is kind of more along kind of the lines of a specialist, but it is unclear whether there is actually a true increased risk in pancreatitis with these particular agents. What does appear to be a more clinically significant risk, though, is the development of cholelithiasis. And the same trial actually did show a statistically significant increase in cholelithiasis. Now, the wrinkle here is that we know significant weight loss of any mechanism is associated with increased risk of gallstone development. So it becomes a little bit difficult to tease out, is this agent specific or is it related, is related to that? to the general weight loss. There are no recommendations that you're screening with ultrasounds before using these medications. If you have somebody that you suspect active gallbladder disease, I would recommend that you evaluate it further before starting the medication, as well as talking about the risks so that the patient knows to seek medical attention or contact you if they develop symptoms. The last adverse effect with this class of medicines kind of concern is about medullary thyroid cancer. And again, if you see commercials for any of these agents on the television, the vast majority of it is going to be spent talking very quickly about kind of the risk of medullary thyroid cancer, as well as a lot of others. So what do we know about the data? So first of all, why were we concerned about it? And so in preclinical studies involving rodent models, there is evidence that the GLP-1 analogs can induce C-cell hyperplasia. This is the cells in the thyroid that lead to medullary thyroid cancer. And although there had been no signal of increased medullary thyroid cancer risk in non-human primates, the FDA, when they approved these medicines initially for the treatment of diabetes, it came with an FDA black box warning. You should not use this medication in patients that have known medullary thyroid cancer or a family history of medullary thyroid cancer or MEN2 syndrome because of the increased risk. Well, what do we actually know about the risk? Now, first, I'm going to show you this study that came out earlier this year, and it's called, there's been a lot of talk about it. So this was a study that came out of France, and they actually used the French National Healthcare Insurance System, and they actually did a nested case control study. So they looked at this, and because of kind of the national healthcare in France, they were able to use the database to look at all patients that had been with diabetes that developed thyroid cancer. And so what they did is they first identified patients with diabetes that had both any type of thyroid cancer as well as medullary thyroid cancer. And then they were matched at approximately 1 to 20, and they were matched on age, sex, and duration of diabetes. And so those were patients that did not develop thyroid cancer. And then they looked at, through kind of, again, the national database and medication history, whether the patient was a current user, a past user, or non-user as far as GLP-1s. And they also looked at DPP-4 in this particular study. And what they did show is that there was a statistically significant association between current use of GLP-1 receptor analog, as well as in both thyroid cancer and the development of medullary thyroid cancer. And at least in kind of higher levels of exposure, there were kind of increased association. I think the most important part of this slide is actually what you see here in green, which was this. The vast majority of patients with diabetes that developed thyroid cancer had never been exposed to a GLP-1 receptor analog. Now, there's been lots of criticisms and concerns about this particular study. So one is that the case control design really only allows for looking at relative measures of effect, right? Which are important, but not necessarily always the most clinically meaningful. So we could say that, someone has a very, very small risk of some outcome. And even if you double that very, very small risk, it's still a very, very small risk, right? Now, I think one of the most important criticisms about this study was the failure to control for obesity, which we know is a risk factor, again, for many things, including thyroid cancer. And there were clearly an increased percentage of patients with obesity in the cases group compared to the control group. There's a potential for kind of a detection bias with a study like this, as well as misclassification bias, right? So again, it was only as good as the data that was entered into the National Health Registry. And one of the things that I think at least brings concerns about that is when they looked at all of the cases of thyroid cancer, over 15% of them were reported to be medullary thyroid cancer in this database. That is not consistent with any kind of cross-sectional prevalence studies that we see in other places, where typically medullary thyroid cancer only accounts for 3 to 5%. They also allowed for very short latency period. So it only needed to be 6 months after kind of exposure to a GLP-1 where they were kind of actually consider it. And that is not consistent with the biology that we know with most cases of thyroid cancer, which are very kind of slow growing. And in fact, when they've looked at other a meta-analysis looking at, again, kind of the risk of thyroid disorders overall. And so this particular one included 45 trials and over 50,000 patients. They did not see a significant increased risk of thyroid cancer. I also think it is noteworthy that our colleagues in Europe do not have any kind of warning about medullary thyroid cancer with the use of these particular medications. So certainly things for us to kind of be aware of and talk about with our patients. I don't believe the data support a significantly increased risk of thyroid cancer or pancreatitis. I think we need to continue to follow these patients. And like with anything, it's talking about a nuanced kind of potential benefits versus risk. But I also think we need to highlight maybe some of the unique things about this class of medications. And just to refresh your memory about 2 important trials related to these medicines. So the LEADER trial was looking at liraglutide in patients with type 2 diabetes, and they showed a significant reduction in 3-point MACE kind of over time. There were similar results with semaglutide in the SUSTAIN 6 trial, and it's data such as these that led to the recommendations that for patients with diabetes, with type 2 diabetes that have cardiovascular disease, that the GLP-1 analogs have really become a kind of a prominent part of the treatment armamentarium. Now, we're actually starting to develop similar data in patients without diabetes. So you may have heard about this press release earlier this year. We've been eagerly awaiting the results of the SELECT trial. So this used semaglutide and looked at kind of major adverse cardiovascular events in patients with obesity, but without diabetes. And the initial result, and this is all we have, it's being released at the AHA later this month, but that 3-point MACE was reduced by 20% in patients with overweight and obesity when they were treated with semaglutide. We also have some data about semaglutide in improving symptoms in patients with obesity that have heart failure with preserved EF as well. So I think that we're going to see more kind of about cardiovascular outcomes here, which will continue to kind of put these medications as prominent and really important therapeutic options for patients with obesity. All right. Well, as of yesterday, we have one more, tirzepatide. So tirzepatide, a little bit different than the other ones I talked about, is that it is actually a dual agonist that activates both the GLP-1 and the GIP receptors. And you can see at 72 weeks, with this particular medication among adults with obesity, we're getting 20% weight losses. So this is starting to approach what we're seeing with bariatric surgery, right? On average, patients lost over 50 pounds with the particular medicine. The other thing I want to point out is that even though this trial had gone to 72 weeks, with the highest doses of tirzepatide, we had not yet seen complete plateauing of weight loss. So we're going to continue to follow those out. And again, here now we're starting to talk about greater than 25% weight loss in over 30% of patients on this medication, over 85 to up to 90% losing greater than 5%. So very clinically significant reductions with a side effect profile that really looks very similar to all of the just GLP-1 analogs alone. In the interest of completeness, I just bring up this medicine. It's very niche. It's mostly so you don't confuse it with semaglutide. So setmelanotide is a melanocortin-4 receptor agonist. So the melanocortin-4 receptor is a very important receptor in the CNS related to appetite, and activation suppresses appetite. It has a very niche approval, mostly for patients that have genetic and syndromic etiologies of obesity, but can be highly effective in patients with those specific health conditions. So back to this, right? Like we're having an increasing number of medications that we can use with increasingly robust reductions in weight. And there are more on the way. So every single one of these niche peptides are being looked at either in development as monotherapy or in combination therapy. You see them here. One of them that's coming is retatrutide, which is a dual or triple agonist, GLP-1, GIP, as well as glucagon. And it has greater weight loss in kind of the initial trials than we're seeing with tirzepatide. So there are only more to come here. Well, one of the things that I want to change and talk about just in the last couple of minutes is kind of bringing this back to with kind of the full treatment of the comprehensive treatment of patients with obesity. So it is increasingly described and recognized that patients with elevated body weights face discrimination and stigma, not only in employment, education, and media, but unfortunately in healthcare as well. And there are a growing number of studies that suggest that healthcare providers and people within healthcare tend to have more negative assumptions about somebody based on higher body weight. They're more likely to hold patients with obesity responsible for their condition, less likely to make eye contact, less likely to touch their patient, and plan on spending less time with their patients. They're also more likely to give unsolicited advice about kind of exercise and weight loss, as well as maybe not do as thorough of an investigation for kind of complaints such as shortness of breath, and kind of more quickly say, this is likely related to weight. You just need to eat less and exercise more. And again, we know that when patients experience discrimination is associated with negative health outcomes. They're more likely to gain weight. They're less likely to come back to kind of seek treatment. And so in the last couple of minutes, as you're thinking about putting these in, like the use of pharmacotherapy, I want you to think about it more kind of in the comprehensive treatment, and to encourage you to reflect on your personal biases and assumptions about patients with obesity. What do you assume about your patients because they have a higher body weight? Do you assume they're going to be less motivated to be engaged in their care? Do you assume they're less concerned about their health care? It's important to use first-person language and non-stigmatizing language. So it's a patient with obesity. I think it's important to ask permission to discuss weight related health behaviors and concerns, and respect your patient's kind of response to that, right? So ask permission. Approach obesity as a complex chronic disease. I cannot tell you how many of my patients, both in my pediatric and adult patients, for me just to say, hey, stop blaming yourself. This isn't just your fault. And kind of recognizing, hey, and we have therapies, like we have treatment that can really help you with your goals. So let's talk about that. And avoid assuming that a patient's symptoms are necessarily just associated to their weight. I think another thing that we need to actually talk about, though, is about access, right? So we're all very aware that, or probably that there is a national shortage on many of these agents right now. And one of the things that I would encourage you is that even though these medicines may be really appropriate as far as treatment, prescribing them, like initiating new patients on some of them right now, it may be better to wait a period of time until the supply chain is kind of in better source. So, and part of my concern is that, again, we know that with interrupted therapy, weight gain comes back. For most patients, when they lose weight, regardless of whether it's through lifestyle modification alone, pharmacotherapy, or even bariatric surgery, for roughly every pound of weight that's lost, approximately 1/3 of that weight is lean muscle mass, right? And we don't have any data that when patients regain the weight, that they're regaining their muscle mass. I would hypothesize to you it's likely predominantly fat mass that's being regained kind of over the time frame. So I do have some health concerns about rapid cycling on and off of these medicines. Also, it's important to recognize that despite obesity affecting patients across kind of socioeconomic status and different race, ethnicities, that access to these medicines, even when they are physically available, is not equal. Medicare is not covering any weight loss medications, even though they are doing more kind of with supporting supporting behavioral interventions as well as bariatric surgery. And even across insured patients, like the coverage for these very effective medicines are highly variable. All right, so just in the final kind of minute or two, and then I'll open it up to question. So just things I want you to walk away with. One is that we do have more and more kind of really promising therapies to kind of support the comprehensive care of our patients with obesity. But all of these agents are designed to be used in conjunction with lifestyle modification, right? And that to consider initiating when a patient, the use of pharmacotherapy in eligible patients when they're establishing care, we really should not be thinking about obesity pharmacotherapy as reserved for patients that have somehow we use the term failed lifestyle intervention. It's really in conjunction with that. With all of the medicines, you want to get them on a maximally tolerated dose and reassess clinical response after 12 weeks. And if they haven't had a significantly meaningful clinical response, that you would discontinue or wean the medicine and consider something else. And we know this is a place where I think there's a real opportunity for personalized medicine, where we can learn which particular patient is going to have the best response to which of the agents that are available. It's important to monitor the patients monthly during the initial 3 months of therapy, and then at least quarterly thereafter. Again, this is not just kind of a plug and play. Let me give the patient the medicine. Great, they've lost weight. My job here is done. We need to continue to kind of assess, including dietary patterns. And I think particularly with these more potent agents, that is incredibly important, making sure that patients are getting adequate nutrition long-term for that, including adequate protein intake. And really understanding that these medicines are part of kind of a long-term treatment for obesity, and that you can anticipate weight regain after stopping the medicines. All right, well, thank you for your attention. I'll open it up to any questions we have from the audience. I don't know if there are questions online that you can answer to.
We can start here in the audience if anybody has any questions.
Great talk, great overview. Thank you. The issues of managing our own preconceptions about patients with obesity and how we approach that. I think really great points. I guess one of the challenges that I'll ask you to comment on is a perception, and maybe it's the wrong perception, that patients come in and they report a number of symptoms or problems that we believe fairly clearly to be associated with obesity because of its impact on their health. And to us, it seems obvious that we want to talk about that to get at what we say might be the root of the issue, and navigating that in a patient, you talk about asking permission to talk about, that issue. So, it's admittedly stereotypical, but a younger person with really bad joint disease or something like that, who's had a high BMI for a really long time, and we just, no, I don't think it's a bias on my part to say, geez, your osteoarthritis 42 is certainly not helped. It may be caused by 20 years of a high BMI for a long time. So you feel that you feel intellectually you want to at least bring that up. So comments about that?
Yeah, so I think
Paraphrase the question.
Yeah, so to paraphrase it, so Dr. Kashinka was asking about just about like how if you have a patient that has concerns that you are concerns that are weight related, how do you address that in a way that's kind of and I think that there's a couple that I would really again kind of push back and say, reflect on what would you do differently if that patient didn't have obesity, right? So again, there have been studies that have shown that that there were students that were given a virtual avatar kind of, and the patient was coming in with shortness of breath. And half of them saw an avatar that had a body weight that was kind of in the kind of healthy range, and half had an avatar and body weight that was elevated in the range consistent with obesity. There was nothing different about the cases, right? They did a different evaluation for the patient that didn't have obesity, and they were more likely to actually say, oh, maybe this could be asthma. You should try a bronchodilator. But I guess I would push back of like, why would you not do the same evaluation? And I know you didn't say that, but and part of the question, but just to be thoughtful of like, am I doing something differently here solely because the patient has obesity and I am making the assumption that their weight is kind of directly doing that? I think you can still, and it is very nuanced, right? Like, and I think it's important to remember that so many of our patients have experienced like bias and discrimination and very negative experiences across a lot of domains. Not everybody has, but a lot have. And they're coming into our offices with that. And we have the opportunity either to reinforce that or actually to provide some different care. And so things that I might say, like you could do with that, I think you could say, like one of the things that sometimes we'll think about is kind of mechanical joint on things. Like, would it be okay if we talk about potential concerns that maybe, or the relationship that maybe weight is related to this? And so, I mean, I think you can kind of still bring it up and kind of with that, but I would, yeah. So I don't know, but a discussion for a longer discussion for another day. But I think there are still ways that you can bring up the topic and do it sensitively and listen to our patients. And what I would say is, if they don't want to talk about it, do you think that like saying, oh, I think that the weight is causing your osteoarthritis, and so you need to eat less and exercise more, is going to be helpful and kind of do that? And Jeff, I'm picking on you. I'm not saying that was your approach.
We have two questions online real quick. One is about food prescriptions. So does
So processed food, yeah, and food prescriptions. There's been a lot of data or like interest in like different like food macronutrient compositions of dietary intake, particularly modulating those or the associated kind of with improved outcomes with obesity, right? So the low carb versus a low fat kind of debate, and really all of those studies have shown maybe there's some really subtle nuances, but really it's actually all of them are working because of a caloric deficit. Now, where I would say there actually is the most interesting data is in ultra processed foods, right? So things where these are often highly palatable kind of items that don't look like any of the original things that they came from. And there's some data specifically with those types of foods that, and they've done some really elegant trials at the NIH, that consuming ultra processed food does stimulate appetite, and people are more likely to eat more and not have some of the same satiety signals. So I think regardless of what someone's body weight is, having a discussion, as they're interested about kind of increasing the number of or reducing the number of highly processed foods in their diet is I think consistent with health.
We'll have one last question online, and then we'll, let's see. GLP-1 agonist for directed management of antipsychotic associated weight gain, stability of psych illness. Yes.
So Dr. Wickstead was asking about kind of thoughts about the use of GLP-1 agonists for the management of antipsychotic associated weight gain. And certainly I think that we know that individuals that are on those medications are at increased risk, many of them increased risk of weight gain. I have not done an exhaustive. I'm not aware that there are data yet specifically about GLP-1 analogs in that population. I can get back to you to Dr. Wickstead. I'll look it up and see. I do know that there have been studies of metformin actually in that, and that's one of the places where potentially metformin maybe has more clinical benefit kind of in the treatment of obesity, and in particular kind of mitigating against antipsychotic weight gain. So that is a place where that I may use that particular agent more. So thanks again. I'll stick around if there are any other questions that people have.
Thank you. Thank you.
Excellent. I was trying to balance out side of the room. It's so broad, and I Well, all right, so someone.
All right.